Today's topic is herpes virus. Learning objectives are general properties, classifications, clinical important herpes viruses. Herpes viridae comprises of group of viruses that possess unique property of establishing latent or persistent infection in their host and undergo periodic reactivation. Morphology of herpes. As in figure shows, this is the linear double-stranded DNA, icosahedral capsid that is red in color, blue round shape that are the tegments. These green color spikes are glycoprotein spikes and red in color is lipid. Lipid and glycoprotein spikes both makes envelope. Now size is larger, 150 to 200 nanometer in size. Shape is spherical with icosahedral symmetry. Linear double-stranded DNA comprising of 125 to 240 kbp nucleotide surrounded by a capsid composed of 162 capsomers. Envelope, lipoprotein in nature, lipid part is derived from the nuclear membrane and protein part, that is the glycoprotein, virus coded and about 8 nanometer long, are inserted into the lipid part. Tegment, bluish round shape, amorphous sometimes asymmetric structure present between the capsid and envelope. This is tegment. Unique feature of herpes virus DNA that the genome contains several repeated genes which undergo sequence arrangement between the members. There is no DNA homology between the members except herpes simplex type 1 and 2 exhibit 50% of genomic sequence homology. Human herpes virus 6 and 7 that exhibits 30 to 50% sequence homology. Replication of herpes viruses takes place in the host cell nucleus and is similar to replication of any other double-stranded viruses. The only differentiation is that linear double-stranded DNA of herpes viruses becomes circular inside the host cell and then replicated by rolling circle mechanism. Classification of herpes viruses: superfamily Herpes virinae, alpha, beta and gamma. Duration of replications and cytopathology in alpha subfamily, that is short 12 to 18 hours, and cytolytic, site of latency in neurons. Genus are simplex viruses, species name that are the official name and common name. In simplex viruses, human herpes virus 1, common name is herpes simplex virus type 1. Human herpes virus 2, common name is herpes simplex virus type 2. Varicella-virus gene species are human herpes virus 3, common name is varicella-zoster virus. Now, beta subfamily. Duration of replication in cytopathology, that is long 24 hours or greater than 24 hours, and replication in cytopathology is cytomegalic. Site of latency is glands of different types and kidney, and genus is cytomegalovirus. Official name of this species is human herpes virus 5 and common name is cytomegalovirus. Duration is long in some that is greater than 24 hours, that is lymphoproliferative in cytopathology, and site of latency is lymphoid tissue present in T cells. Genus is Roseola virus. Of species name, that is official human herpes virus 6. It is also in common name human herpes virus 6, and 7 is also called as a human herpes virus 7. Now, gamma, duration and replication and cytopathology is variable lymphoproliferative. Site of latency is lymphoid tissue B cells. Genus is Lymphocytovirus. Official name is human herpes virus 4. Common name is Epstein-Barr virus. Genus Rhinovirus. Species human herpes virus 8. And common name is Kaposis sarcoma associated herpes virus. Herpes simplex viruses belongs to alpha subfamily of Herpes viridae, extremely widespread and exhibit a broad range of hosts. However, the human herpes virus infect exclusively men, replicate fast 12 to 18 hour cycles, spread fast and cytolytic. Spectrum of disease are in skin, mucosa and various organs. Undergo latency in nerve cells, reactivate later and causing recurrent lesions. Difference between HSV1 and HSV2. Properties. Transmission. In herpes simplex virus 1, direct contact with mucosa or abraded skin. In herpes simplex virus 2, mode is sexual mode or vertical mode. Latency is trigeminal ganglia in herpes simplex virus 1 and in sacral ganglia and in herpes simplex virus 2. Age affected in type 1 is young children. In type 2 it is a young adults. Antibody distribution in adults presents in 70 to 90% of people and type 2 present in 20% of people. Common manifestation of herpes simplex virus 1 is first, oral facial mucosal lesion. Second is encephalitis and meningitis. Third is ocular lesion. Fourth is skin lesion above the waist. Herpes simplex virus 2. Common manifestations are genital lesions, skin lesion that are below the waist, and third is neonatal herpes. In egg, herpes simplex virus 1 forms smaller pox and type 2 forms larger pox. Cheek embryo fibroblast doesn't grow herpes simplex virus 1 and type 2 it replicates well. Neurovirulence in herpes simplex virus 1 is less and drug resistance is also less. In herpes simplex virus 2, neurovirulence and drug resistance is more than type 1. Antigenic homology is greater than 80% homology is present. Genomic sequence homology is greater than 50% in type 1 and 2. Pathogenesis, first primary infections. Transmission occur through the abraded skin or mucosa, site of infection that replicates the local site of infection and produces lesions, commonly in HS1 lesion confined to above the waist, most common around the mouth. In HSV2, it is below the waist, most common site is genital area. Spread via nerves. Virus then invades the local nerve endings, then transported by retrograde axonal flow to the dorsal root ganglia, replicate further, undergo latency. Primary HSV infection are usually mild, most are asymptomatic. In immunocompromised host, viremia occurs that leads to widespread organ involvement and systemic manifestations. HSV has a tendency to undergo latency in neurons. HSV1 will go in latency in trigeminal ganglia, and type 2 will go in sacral ganglia. Non-replicating state. HSV does not replicate in latent stage except for a small RNA called microRNA, which maintain the latent infection and prevent cell death. Viruses cannot be isolated during the latent period. Recurrent infections. Reactivation of these latent viruses are following fever, axonal injury, physical or emotional stress, and exposure to UV lights. Via the axonal spread, virus goes back to peripheral sites and further replicates in skin or mucosa and produce secondary lesions. Recurrent infections are less extensively and less severe because of presence of pre-exciting host immunity that limit the local viral replications. Many recurrences are asymptomatic, but viruses are shed in the secretion. Clinical manifestation in details. Figure show vesicular lesion on lips and tongue due to the herpes simplex virus 1 infection. That is the orofacial mucosal lesion. Most commonly affected site, buccal mucosa. Most frequent primary lesion, that is a gingivostomatitis and pharyngitis. Most frequent recurrent lesion in herpes labialis, painful vesicles near the lips. Other lesions that are the ulcerative stomatitis and tonsillitis. Many cases that are the asymptomatic but can predispose to secondary infection by bacteria such as pneumococcus and streptococcus. In nervous system, it causes encephalitis, meningitis, and other infection manifestation are autonomic nervous system involvement in sacral ganglia, transverse myelitis, Guillain-Barré syndrome, and peripheral nervous system involvement cause Bell's palsy. Cutaneous lesions, herpes whitlow, febrile blister, herpes gladiatorum, eczema herpeticum, and erythema multiforme. Ocular lesion, figure shows periocular vesicular lesion due to the HSV-1 infections. More common in HSV-1 than HSV-2. Severe conjunctivitis is the most common manifestation. Genital lesion is more common in HSV-2 than HSV-1. That is bilateral, painful, multiple, tiny vesicular ulcers associated with fever and inguinal lymphadenopathy. Visceral and disseminated herpes. Risk factors are immunocompromised patient, underlying malnutrition or AIDS patient, pregnant woman, transplant recipient that are the high risk of developing viremia and disseminated infection. Common manifestations are pneumonitis, tracheobronchitis, and hepatitis. Neonatal herpes. Transmission during the birth from maternogenital tract, in utero, or after the birth of baby. Risk of developing neonatal herpes is maximum 10 times more if the mother recently acquired the virus primary infection than those who are presented with recurrent infections. HSV-2 is more common to cause neonatal herpes, 75% of total cases, than HSV-1. Clinical features of neonatal herpes. Babies are almost always symptomatic and presenting one of the three forms, that is local lesion involving skin, eye and mouth, encephalitis, disseminated disease involving multiple organs including the CNS. Neonate has the highest frequency of visceral infections. Epidemiology. In HSV-1, children are the commonly affected wherever HSV-2 occurs in adult life. HSV-1, adults antibodies developing 70 to 90%, but they fail to eliminate the virus from the body. Antibodies develop only in 20% of people, particularly among black women, than men, and whites in HSV-2. In HSV-1, most adults become carrier throughout the life. occasionally get transient recurrent attacks. In HSV2, it tends to reoccur more often than HSV1, irrespective of the site of infection. Lab diagnostic. By Wright's or Giemsa stain, cytopathology by Zhang smear preparation. Virus isolation, viral antigen detection by direct immunofluorescence test, HSV DNA detection by PCR and real-time PCR, antibody detection by ELISA or other formats. We will see cytopathology. Figure shows Zhang smear of tissue scraping showing Zhang cells. That is bluish in color. Scraping obtained from the base of the lesion can be stained with Wright's or Giemsa stain or Papanicolaou stain. Sensitivity is less than 30% for mucosal swab. Cannot differentiate between HSV1 and 2 and varicella zoster virus, as all of them produce similar but characteristic cytopathologically change such as Cowdroy type or intracellular inclusion body, that is a Lipska's body, multinucleated giant cell, ballooning of infected cell, margination of chromatid. Virus isolation remains the most definitive tool for HSV diagnosis. Growth inside the cell line can be detected in 2 to 4 days by characteristic cytopathic effect that diffuses rounding and ballooning of the infected cell. Viral antigen detection by neutralization test or immunofluorescence staining with specific antiserum. Shell vial technique can be followed to decrease the detection time to less than 24 hours. Detection by immunofluorescence, staining with specific antiserum, sensitive and specific assay can differentiate HSV1 from 2. DNA detection by PCR, that is the most sensitive, and differentiate HSV1 and 2. Real-time PCR targeting genes glycoprotein B and UL30. More sensitive, can quantitate the viral load in specimen and also can differentiate HSV1 and 2. Figure shows indirect immunofluorescence test for HSV1 and 2 antibody detections. Antibody appears in 4 to 7 days after the infection and peak in 2 to 4 weeks. IgM appear first and is replaced by IgG, which persists for life. Treatment. Acyclovir is the drug of choice. It acts by inhibiting viral DNA polymerase. For mucocutaneous infections, acyclovir and its congener famciclovir and valciclovir have been the mainstay of the treatment. Ocular infection, topical idoxuridine and trifluorothymidine, topical vidarabine and cidofovir are used. For HSV encephalitis and neonatal herpes, IV acyclovir is the treatment of choice. Acyclovir resistant will give forsanate is the drug of choice. Prevention. To prevent the genital herpes, use of condom. Neonatal herpes can be prevented by prior administration of acyclovir to mother during 3rd trimester of pregnancy or delivery by C-sections. No vaccine is currently licensed. Several vaccine trials are going on, such as recombinant HSV2 glycoprotein vaccine. Now, varicella zoster virus. It produces vesicular eruptions, rashes on the skin and mucous membrane in the form of two clinical entities, that is chickenpox, generalized diffuse bilateral vesicular rashes following primary infection and usually affecting children. Zoster occurs following reactivation of varicella zoster virus present in the trigeminal ganglia that occur mainly in the adult life. Vesicular rashes are unilateral and segmented. Chickenpox. Portal of entry, upper respiratory mucosa or the conjunctiva. Spread. It replicates in the regional lymph node, spills over and enters the bloodstream, that is primary viremia, spread to the liver and spleen and multiply in it. Against enter bloodstream, that is the secondary viremia. Wizard be present in the infected mononuclear cell that are transported to skin, cause virus replication in the epithelial cell and cause rashes. Swelling of epithelial cell, ballooning degeneration and accumulation of tissue fluid result in formation of vesicles. Other site is respiratory tract. It sets in the respiratory secretion and transmission of infection occur. In neurons, it gains access to neuron of trigeminal ganglia and undergo latency. First figure shows rashes of chickenpox. Second one is a segmental distribution of rashes of zoster. Incubation period 10 to 21 days or 2 to 3 weeks. Typical description of chickenpox rashes are rashes are the vesicular, centripetal in distribution, bilateral in diffuse in distribution. Rashes appear in multiple crops. Fever appear with each crop of rashes. Disease of children, when occur in adult, it is more severe with bullous and hemorrhagic rash. Complication. Most common infectious complication is secondary bacterial infection of skin. Extracutaneous complication are CNS involvement, usually occur in the children, that are the encephalitis, aseptic meningitis, cerebellar ataxia. Most serious complication is pneumonia that develops more commonly in adults than in children and particularly severe in pregnant women. It causes Ray's syndrome and other complications that are the myocarditis, nephritis, corneal lesion and arthritis. Chickenpox in pregnancy can affect both mother and fetus. Mother are at high risk of developing varicella pneumonia. Fetus can develop two types of infections depending on the gestational period. Fetal or congenital varicella syndrome that occurs in early pregnancy and neonatal varicella infection near the delivery. Congenital or fetal varicella syndrome. It is highly teratogenic, maximum risk when mother is infected. Acquires infection at early pregnancy. Risk of transmission is 25% and developing into disease is 0.4 to 2% of infant whose mother gets chickenpox in less than 13 weeks and 13 to 20 weeks of gestational respectively. Characterized by cicatrizal skin lesion and limb hypoplasia. CNS defect, microcephaly, mental retardation and seizure. Ocular defect, chorioretinitis, microophthalmia and cataracts. Renal system, hydroureter and hydronephrosis. Autonomic system, neurogenic bladder and low birth weight. Neonatal varicella occurs if mother develops chickenpox more than 5 days before delivery. Then baby is mostly asymptomatic due to the protective maternal antibody inspired transmission occur during the delivery. If mother develops chickenpox 5 days before to 2 days after the delivery, maternal antibodies would not have produced in such a short time, leads to dissemination of virus in the baby to cause neonatal varicella. Epidemiology. Chickenpox is a highly contagious disease. Period of infectivity. Child is infectious from 2 days before the onset of rash to the 5 days after until the vesicles are crusted. One attack gives lifelong immunity. Reservoir. Humans are the only reservoir host. Sources of infections. Patients are the only source. No carrier. Secondary attack rate is 70 to 90%. Due to the reactivation of latent wizard V in old age greater than 60 years of age, in immunocompromised individual or occasionally in healthy adults, start with severe pain in the area of skin and mucosa supplied by one or more group of secondary nerves and sensory nerves and ganglia. Rashes are unilateral and segmental, confined to the area of skin supplied by the affected nerves. Most common nerve involved are ophthalmic branch of trigeminal nerve. Head, neck and trunk are the most common affected site. Complication: post-herpetic neuralgia, zoster, ophthalmicus, Ramsay-Hunt syndrome and visceral disease. Lab diagnosis: cytopathology by Ginsa staining of scraping from the ulcer base, that is a Zhang smear, reveals cytopathological changes similar to the HSV, such as formation of multinucleated giant cells. Virus isolation in various cell lines also produce HSV-like cytopathogenic effect, diffuse rounding and ballooning of the infected cells. Specific method that includes direct immunofluorescence staining that detects specific antigen, PCR detecting wizard with specific genes, vaccine. Live attenuated vaccine using OCA strain of wizard B is available. Given to children after 1 year of age, 2 doses. First dose is given at 12 to 15 months and second is 4 to 6 years. Also given to seronegative adults, 2 dose, 1 month gap. Transmission of the vaccine virus can occasionally cause mild rash in the recipient. Protectivity: vaccine is greater than 80% effectivity in preventing chickenpox in children, but less so in adults, that is 70%. However, it is 90% effective in preventing severe diseases. Treatment is acyclovir in the drug of choice. Can prevent the complication of chickenpox and can also the progression of zoster in adults, but cannot prevent post-herpetic neuralgia. Varicella zoster immunoglobulins that are recommended for post-exposure prophylaxis, preferably given within 96 hours, preferably 72 hours of exposure. Also indicated for neonates born to mother suffering from chickenpox if the onset of chickenpox in the mother is between less than 5 days before delivery till 48 hours after delivery. Varicella zoster immunoglobulin not indicated if the mother has zoster. Infection control measures: first one is isolation, second is airborne precaution, negative air flow rooms, plus contact precaution must be followed until lesions are dry and crusted. For localized zoster in immunocompetent host, contact precaution also can be followed. Now, cytomegalovirus, that is the largest virus in Herpes viridae family, named because it caused massive enlargement of infected host cells. Properties of CMV are similar to any other herpes virus described earlier with some minor differences. That belongs to beta subfamily. Double-stranded DNA is the largest among herpes virus. Strictly species specific, cell type specificity in vivo that infects kidney and salivary glands where it undergo latency. In vitro, CMV replicates only in human fibroblast cell line and produces a characteristic cytopathic effect described as a owl's eye appearance. It causes cell-to-cell spread. Clinical manifestation are congenital, perinatal infection, infectious in immunocompetent, and infection in immunocompromised and transplant recipients. Congenital CMV infection: most common intrauterine infection associated with congenital defect. About 1% of infants born are infected with CMV. Inclusions disease develop in about 5% of infected fetus. 5 to 25% of them may develop significant psychomotor, hearing, ocular or dental defect within 2 years. Congenital defects that includes most common defect are erypetechi, hepatosplenomegaly and jaundice, 60 to 80% of cases. Less common defects include microcephaly, cerebral calcification, intrauterine growth retardation and prematurity in 30 to 50% of cases. Risk maximum if the infection occur in early pregnancy, and if mother is primarily infected during pregnancy, 1/3 of the primarily infected mothers transmit virus to fetus, to contrast to 1% reactivated mother. Perinatal CNV infection. Transmission to the newborn occurs either during delivery through infected birth canal or postnatal through infected breast milk secretion from the mother, mostly asymptomatic but shed via in urine from 8 to 12 weeks of age up to several years. Few infants, especially premature babies, develop interstitial pneumonia. Immunocompetent adults. Mononucleosis-like syndrome. What is the difference between infectious mononucleosis and mononucleosis-like syndromes? Agents in infectious mononucleosis are Epstein-Barr virus and mononucleosis-like syndrome, CMV, that is 20 to 50%, HHV6 and Toxoplasma aeruginosa HIV. Atypical lymphocytosis are seen in infectious mononucleosis and mononucleosis-like syndrome. It is seen. Clinical symptoms in infectious mononucleosis are fever, myalgia, hepatosplenomegaly, exudative pharyngitis, cervical lymphadenopathy, rashes following ampicillin therapy. In mononucleosis like syndrome, similar presentation except exudative pharyngitis, cervical lymphadenopathy and cervical lymphadenopathy that are the absent. Heterophile antibodies are elevated and mononucleosis-like syndrome, it is negative. Specific antibody to specific EB antigen are elevated. Antibodies to CMV or other antigens may be elevated in mononucleosis-like syndrome. In an immunocompromised host, in untreated AIDS patients that have CD4 count less than 50% per microliter, CMV may cause chorioretinitis, gastroenteritis, dementia, and other disseminated CMV infection. Organ transplant recipient. Most common viral infection 1 to 4 months post-transplantation, that are the bilateral interstitial pneumonia is the most common form seen in 15 to 20% of bone marrow transplant recipients. Febrile leukopenia is seen among solid organ transplant recipients. Obliterative chorioretinitis, obliterative bronchiolitis in lung transplant, graft atherosclerosis in heart transplant, rejection of renal allograft. Epidemiology. Transmission by oral and respiratory spread is the predominant mode. Transplacental route, transmission from mother to fetus. Blood transfusion, risk is 0.1 to 10% per blood unit transfusion. Organ transplantation, sexual contact in young adults. Reservoir, humor are the only reservoir. Source, virus may be shared in urine, saliva, semen, breast milk and cervical secretion and is carried in circulating white blood cells. It is endemic in worldwide, presents throughout the year without any seasonal variation. Risk factors are low socioeconomic status and poor personal hygiene that facilitate the infection. Prevalence is high in underdeveloped nations with 90% of people being seropositive in contrast to 40 to 70 seropositivity in developed nations. Lab diagnosis, detection of inclusion bodies in urine, characteristic perinuclear cytoplasmic inclusion in addition to the usual intracellular inclusion seen in herpes virus. It shows owl's eye appearance that is present in figure. Virus isolation from throat washing and urine. Human fibroblasts are the most ideal cell line. Cytopathic effect after 2 to 3 weeks of incubation. The following CPE may be observed. Typical CMV inclusions, multinucleated GN cells seen, and enlargement of infected host cells. Shell vial techniques. Very useful in CMV mononucleosis where viral load is low and CPE takes several weeks to appear. Antibody detections. ELISA has been available for detecting serum antibodies against various antigens such as matrix phosphoprotein PP150 and PP65, glycoprotein G, B and GH, major DNA binding protein that are the PP52. CMV IgM antibodies appear in 1 to 2 weeks after infections and indicates recent or ongoing infection. Drops to below detectable level within several months after infection. IgM detection in pregnancy indicates congenital infections, thus guiding initiation of appropriate treatment. CMV IgG antibodies are produced few days after IgM and persist lifelong, indicate either a recent or past infection which can be differentiated by performing IgG avidity test. Low IgG avidity indicates recent infection less than 3 weeks. IgG avidity test is also useful in congenital diagnosis infection, and antibody detection cannot distinguish strain difference among the clinical isolates. Antigen detection. CMV specific PP65 antigen, it is the major matrix phosphoprotein, can be detected in peripheral blood leukocyte by indirect immunofluorescence test using specific monoclonal antibody. Test has been used since long but is less preferred as it is time consuming and technically demanding. Molecular method PCR. To detect specific CMV DNA in blood or body fluid such as CSF. Various genes targeted are glycoprotein B, DNA polymerase and PP65. PCR also rapid, highly sensitive, specific and have replaced the gold standard culture technique in most laboratories. Real-time PCR can quantitate the viral load, hence it is the method of choice to monitor treatment response. Treatment is CMV does not respond to acyclovir. Following drugs are used to treatment of this infection, that are the ganciclovir, valganciclovir, foscarnet, cidofovir and CMV immunoglobulin. Antiviral resistance can occur rarely due to the mutation in the target genes. For example, UL97 mutation confers resistance to ganciclovir, while UL54 mutation leads to resistance to ganciclovir, cidofovir and foscarnet. Prophylaxis. Both ganciclovir and valganciclovir have been used successfully for prophylaxis and presumptive therapy in transplant recipient. CMV immunoglobulin has shown to be effective in preventing congenital infection when given to mother during pregnancy. Thank you.